You're listening to Medscape's In Discussion series on colorectal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Benjamin Schlechter. Dr. Schlechter is an academic medical oncologist at Dana-Farber Cancer Institute and instructor in medicine at Harvard Medical School. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Benjamin Schlechter, and welcome to Medscape's In Discussion series on colorectal cancer. Today we're discussing the care of older adults with colon cancer with Dr. Nadine McCleary. Dr. McCleary is an associate professor of medicine at Harvard Medical School and a medical oncologist in the Gastrointestinal Cancer Center at the Dana-Farber Cancer Institute. She's also a leading voice in the care of older adults with cancer. Dr. McCleary, first, I'd love to hear more about your path to GI oncology and what led you to focus on the care of older adults with this disease.
Thank you so much, Dr. Schlechter. I would say it started with growing up in Miami, Florida, and witnessing the variety of older adults that I came into contact with throughout my days there. Volunteering in the hospital, seeing those who were at their most frail and vulnerable, but in my general community, particularly within my church, seeing those who were quite vibrant and active and actively engaged within their communities. When I matriculated first to my undergraduate program in nursing and then medical school, I understood there was a formal study of older adults and their needs and their capacities and ways to build and measure resilience. That fascinated me in the field of geriatric oncology. And I selected gastrointestinal oncology because of the breadth of diseases and ages that it affects, but also the volume of older adults who are diagnosed with gastrointestinal cancers every day.
When you meet an older adult with cancer, what assessments or techniques do you use to fit your care to their specific needs as a cancer patient?
I think the first assessment that needs to happen is, what are your goals of care? What are the things that are most important to you? I always ask about functional ability. How do you move through your day? What does your day typically look like? Who are the folks you like to have around you? How do you like to spend your time? So understanding who my patient is probably the best and most important assessment. But there is a formal assessment called a comprehensive geriatric assessment, and we use that in gerontology quite frequently as a primary measure of geriatric syndromes or disease states or conditions that older adults may be faced with. Things like cognitive impairment or physical frailty, functional debility. Those are very important topics that come up in the field of older adults or geriatric medicine. When we add on a layer of cancer, there actually is an assessment that has been modified for the field of oncology by Dr. Artie Huria and Dr. Martine Eksterman and others, borrowing from geriatrics to understand what are the implications of a cancer diagnosis in the older adult, in an aging person, and how do we need to capture concurrent medical conditions, concerns about multiple medications or polypharmacy, concerns about social status, and sometimes the need to have care partners or care proxies. How do we factor all of that in, along with some of the kind of physiologic changes that happen? So organ reserve tends to decline for patients. There's a concern of interactions with medications and nutritional status, for example, that need to be considered. So the comprehensive geriatric assessment as it applies to cancer becomes incredibly important. And then it's yielded a lot of optimal measures of outcomes so we can better understand how a patient may progress through their care.
And just in terms of thinking about a busy clinician seeing patients on a day-to-day basis, what are some really basic pearls for things that, me as a GI oncologist, what would you want me to be asking my patients that might get me part of the way there, maybe not the expertise of a geriatric oncologist, but maximize the benefit for patients?
So there are emerging kind of first-line measures that we'd love to promote from the geriatric oncology perspective, all clinicians use, which is gait speed. So how fast an older person can walk over a certain prescribed distance is highly predictive of outcomes, of toxicity, and of frailty in general. But it's not always easy to do. You may not always have the space to do it, and particularly in this post-COVID era, and I'm happy to say post-COVID pandemic era now, where we're doing more and more virtual visits, that may not actually be practical. Grip strength has also been recommended as a measure, but again, having the tools to do grip strength is not always feasible. I like to ask a question about falls or number of falls within a 6-month period, because that has been, whether cancer or not is diagnosed, has been associated with survival. And so having one fall in a 6-month period of time certainly does show to be associated with inferior survival of poor outcomes and associated with frailty. So if you have a patient who has fallen within the past 6 months, your ears as a clinician should perk up to say this patient may need additional support at home. I also ask about social status. We know that older adults who are living alone and facing a cancer diagnosis and treatment decisions may have a harder time kind of navigating that space. And so thinking about how to increase support for patients in the form of social work consultation and other adjuncts within their communities, such as meal preparation services, is also highly important. The next piece that I think a busy clinician can easily do is count the number of medications that your patient is taking on a day-to-day basis. There's a growing body of literature that suggests that polypharmacy, or having more than 8 medications on a daily basis that need to be managed, is indicative of a risk of poor outcomes, because that increases your likelihood of having medication errors in terms of administration and or drug interactions.
Excellent. Super helpful and really high yield too. So let's move into chemotherapy. And I want to focus a bit on colorectal cancer and early stage disease. So how do you think about adjuvant therapy, curative intent therapy in this special older adult population?
Right. So if we're fortunate enough to meet with an older adult as a medical oncologist, acknowledging that many are not referred to meet with a medical oncologist for this discussion, I think one of the first things that's important for us to acknowledge is what is the person's baseline functional status. Presuming they're well enough with a ECOG performance status of 0 to 1 and a low geriatric frailty score where they're deemed to be more fit and robust, then you do want to think about their life expectancy and balance, whether they are diagnosed with multiple medical conditions or not. You can look at the NCCN guidelines, which are pretty helpful in terms of life expectancy. There's also many prognostic scores with e-prognosis through the UCSF website that can be quite helpful in predicting prognosis. But if you determine that the life expectancy with untreated cancer is shorter than the life expectancy with treated cancer, then you should certainly talk about offering treatment. Because of the data from the IDEA trial that showed us that giving a shorter duration of chemotherapy is as beneficial in patients with a disease that is at lower risk for recurrence, I am more prone now to offer full adjuvant therapy for my patients, including the use of oxaliplatin. But I and others have shown in the past that oxaliplatin is not always beneficial for all older adults who are diagnosed with a potentially curable cancer. And so being open about the potential risks and benefits, particularly for those who have more invasive disease or a disease that is at higher risk of recurrence, T4N2 disease, where 6 months of chemotherapy may be recommended, is really a conversation. What I have learned from our work with the Accent database and our colleagues with NSA-BP CO7 and the Mosaic studies showing that not all older patients derive benefit from oxaliplatin is that I may offer it for the first 3 months and then really reassess after that point and continue only with fluoropyrimidine through month 6 for those patients with more aggressive but yet curable disease.
And which fluoropyrimidine do you reach for? I feel like in my clinical practice, I'm generally more comfortable with infusional 5-FU, and it feels like it's easier on patients, but it's hard to know where opinion ends and science begins. What's your choice, and are there risks and benefits that are known for, say, capecitabine versus 5-FU?
Yeah, I would say opinion, science, and then there's the issue of logistics. And so with older adults, thinking about organ reserve, if someone has renal insufficiency, clearly capecitabine is not and should not be your choice of agent for that. Infusional fluorouracil is the better option. But in patients who have preserved renal function, where you truly do have an opportunity to make a choice, even in those patients prescribed 3 months of therapy, I also tend to lean towards infusional fluoropyrimidine. I recall an editorial that Dr. Bob Mayer published many years ago, considering logistical implications of capecitabine in patients, even though the science showed similar efficacy. Logistically, taking an oral medication that you have to take in multiple strengths throughout a particular period of time can be somewhat complicated for an older adult who tends to have more medications on board to manage anyway, whereas infusional fluorouracil offers you the opportunity to meet with your patient prior to administering that therapy and to really have a more timely check of their tolerance of the treatment and then make timely adjustments. For those who do proceed with taking a capecitabine therapy or prescribing that rather, I strongly advise that you check in with your patient more often in the beginning, certainly within the first 1 to 2 cycles on a weekly basis to ensure that they truly are tolerating their therapy. We do know that at least that some older adults may not want to bother you, may not want to share that they're not having an easy time or tolerating their therapy. And so those check-ins can prove to be high yield to keep your patient out of the emergency department, out of the hospital, but reduce any morbidity from treatment.
Super helpful. And do we know anything about the economic impact on patients? And this may be sort of beyond the scope, the economic impact on patients doing infusional 5-FU versus capecitabine, which may fall into a drug plan, which can be more challenging for adults on Medicare. So that's something that you're aware of has been studied or looked at?
So I recall in Dr. Mayer's editorial, that was one of the key take-home points at that time. Capecitabine was a bit newer and novel, and so the cost was fairly higher. I think it's important to consider that there are unmeasured costs in oral medications. I alluded to some of the unplanned resource utilization in terms of ED visits and hospitalization, but to my knowledge, that has not been formally studied and measured compared to infusional fluorouracil. I think, though, there are some unintended consequences when we think about the convenience of a medication for patients who opt not to be compliant with that medication, and we know that is a challenge with any oral therapeutic that we prescribe. So I recall an example of a patient who had a curable cancer who certainly confirmed that they were compliant with their medication, and it wasn't until a diagnosis of metastatic disease that they revealed that they had not been compliant with taking that medication. And it is very hard for us to capture that earlier. We do have to rely on our patients telling of their compliance. So I think if there's any concern that we are running into a risk of not having the best outcome from therapy, and you want to monitor that carefully, infusional would probably be not only the most effective clinically, but also cost-effective in terms of the long run.
Excellent. Thanks for that. And now you mentioned a patient who developed advanced disease. So let's talk about advanced disease. You've recently published some troubling data on outcomes in older adults with metastatic colorectal cancer. And in particular, you showed that the benefit in PFS was pretty good with combinational chemotherapy in the first line, but actually OS was inferior. And I actually was really concerned when I read this. Can you help us understand this issue and how we should incorporate these findings into clinical practice?
Yes, thank you. You bring up another excellent data source, which is the ARCAD database, which is a pooled analysis of many of the studies that are published around advanced colorectal cancer. And one of the challenges and the reason that we can't fully understand the lower overall survival that was observed with first-line therapy is because we don't have clear measures of the causes of death for patients diagnosed with colorectal cancer as a population, but specifically for older adults where there are other competing causes of death. In the past, I've looked at, and others have as well, concurrent medical conditions and the frequency in which those occur for older adults. But in terms of cause of death, that data is rarely, if ever, included in prospective clinical trials, which is where we derive our treatment recommendations. And so I think to fully understand the overall survival decrease that we're seeing and to understand if that is attributable to the cancer diagnosis or some other cause like diabetes or unmanaged heart failure, we really need to prospectively collect that data.
Yeah, that's helpful. When I read that, my thought was that we were making CAT scans look better, but patients look worse, that the toxicity of therapy was overcoming any benefit. So
I think that's one possibility, but I think you bring up another excellent point, which is in clinical trials, the endpoints that we're looking at often in oncology are survival-based, and that may not be the most relevant outcome to measure for older adults. And it has been proposed by Dr. Hurrier, Dr. Exterman, and many others, this idea of quality of survival or time to deterioration in symptoms, this concept of patient-reported outcomes, really measuring the quality of life over the quantity that is probably the most relevant to decision-making for older adults.
Thank you for that clarification. Now, you also published data showing that older adults were both less likely to receive second-line therapy, but that they also do just as well as younger patients when they do receive second-line therapy. So could some of this decrement in survival be a lack of second-line therapy that older patients are deprived of since the ones who do receive it are deriving benefit, at least in the second-line trials?
Yeah, that is one of our hypotheses is that, if those patients were able to receive second-line therapy, they would still derive benefit. And in fact, the survival benefit that we saw in second line mirrored that of the first-line studies. But yet it remains to be seen. There's some gaps in the data, and I think it really encourages all of us as we, design our studies to be careful in collecting information that's going to help us to answer these questions better. That is, how do we select those patients who go on to second-line trials, and what happens to those who don't? Or how do we select in the real world patients who opt for ongoing therapy and those who decide not to? So it reminds me of work that Dr. Sanoff and others have published looking at the SEER Medicare database, which kind of better captures what happens in the real world. And at least in the first line, they were seeing similar findings of lower referral or lower receipt of therapy for older adults. And it would be interesting to look at that data in regards to second-line therapy as well.
And when you're seeing a patient who's made it through first-line therapy successfully, such as it is, but needs second-line therapy, which it's an interesting term for success or first-line therapy, what do you look for that makes you think this is the right person to move on? Does the prior regimen's toxicity, let's say going from FOLFOX to FOLFIRI, does that inform your decision? Is the frailty of the patient? What are some of the things that you look for when you make the decision to proceed to second-line treatment?
I guess it's similar to what I look for when I make the decision for first line, which is how does this align with the patient's goal of care? How did we improve upon their quality of life, even if the scans are not as we would like them to be and show progression of disease? But is that patient continuing to function well? Are they remaining as independent as they choose to? Do they have the social support that are needed? And then, of course, we want to look at the disease measures and how much benefit did we derive from that therapy? How many hospital visits did they have to get through that therapy to make it, quote unquote, successful? And if all of those things kind of measure up, again, after having that full conversation with the patient and their care partners, then you would certainly want to move forward. I always add the caveat, however, that when we make these decisions about therapy, whether first line, second line, or beyond, we always leave the opportunity for rediscussion and a new decision. So if we are not meeting our goals of disease control and quality of life, maintenance of relative independence, and it remains the patient choice, then maybe we need to reconsider.
That's super helpful. So Dr. McCleary, if you had a blank check, you could do the perfect clinical trial to help us understand how to deliver care for older adults with colorectal cancer in the palliative setting, for example. What would you do? What's the perfect clinical trial for these patients?
So that is an easy question. It turns out between the NCI, ASCO, ECAR, RTOG, Alliance, NCORE, all of these groups now coalescing, but really led by leaders from the Cancer and Aging Research Group, we've answered that question, which is that we need to incorporate outcomes that are relevant to the needs of older adults. And we need to include measures that really give us a more comprehensive picture of the patient that we are screening for trial and are enrolling to study. So that includes incorporating a comprehensive geriatric assessment in each of these clinical trials, including more pragmatic eligibility criteria for each of these clinical trials, where we lessen restrictions by age arbitrarily, and we lessen restrictions by concurrent medical conditions where they are well controlled and do not interfere in the benefit of the potential therapeutic agent. And then I think we need to, in this world where we're thinking about patient-reported outcomes more and more and thinking about them as potential outcome measures, but also quality measures, really acknowledge that geriatric assessment is probably one of the first and earliest validated patient-reported outcome measures. And so for us to be able to answer these questions, again, with that blank check in front of us, we should be incorporating all of these concepts. The last thing that I would say is that oftentimes when we speak about older adults, we are still speaking about them as a monolithic group, and they are not. They are an incredibly diverse population of folks, and I think a part of our measures should reflect not only that diversity in terms of functional status and social status, but also in terms of identity, in terms of sociodemographic, in terms of financial distress. All of those views of who an older adult is, I think would help us to have the highest yield clinical trial.
Yeah, that's helpful. In a disease of the aging, although we hear a lot about young onset colorectal cancer, which is a critically important topic, but this still remains a disease of older adults. And our experience as clinicians, I think, is refined by the work that you're doing. And I really appreciate the work that you've done to help us know what we can do to help improve the outcomes for these patients and to study how they're doing, because it's a real challenge to try and average patients into a clinical trial when clinical practice really doesn't always reflect clinical trials. So today we've been speaking with Dr. Nadine McCleary discussing the management of older adults with colorectal cancer. We've been discussing the risk and benefit ratio of adjuvant therapy, and in particular, the fact that, when we talk about our fluoropyrimidine backbone, there may be advantages to infusional 5-FU over capecitabine, not just advantages in terms of quality, but also the economic impact of an oral drug and the burden on the patient of an oral drug. We also talked about the fact that oxaliplatin remains an effective drug, and we can use the data from the IDEA collaborative study that 3 months of chemotherapy can still give substantial benefit to fit adults. In the palliative setting, Dr. McCleary has shown us that there are some troubling signs about overall survival outcomes, but it's not clear these are cancer-related decrements in overall survival or related to general health. And finally, we've had some important points about how to care for these patients and maximize benefit. I think we might need to resuscitate walking our patients from the exam room to see how they do. And yeah, I know from our practice seeing you do that. And I think that's some good old-fashioned doctoring that we need to bring back, because it's a time to talk to our patients, to see them walk. And also, that is our geriatric assessment. Can you make it from here to there? Ask them about falls and their balance. And so I think that's great. And I love the term that you used. We need to assess quality of survival. I think it's a great way to assess outcomes in a really holistic and thoughtful manner. So thank you again for this really fascinating discussion.
Thanks for listening to Medscape's In Discussion Colorectal Cancer podcast series with our host, Dr. Benjamin Schlechter. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on colorectal cancer.